Fastest Ebola outbreak ever recorded spirals deeper into crisis. World's fastest Ebola outbreak raises fears of international spread. The fastest-recordedla outbreak has killed more than 1,000 people in the Democratic Republic of the Congo after accelerating at a speed that has stunned health experts. More than 2,500 confirmed infections have now been recorded, with the outbreak reaching its first 1,000 deaths in just over 2 months, far faster than the catastrophic West African epidemic of 2014 to 2016. This is no longer a small or geographically isolated flare-up. Cases have spread across 5 Congolese provinces, scores of health zones remain active, and an alarming proportion of infections are appearing outside the contact networks authorities are supposed to be monitoring. The central fear is not merely that the figures are rising, but that the outbreak is expanding faster than the containment operation can identify where the virus will appear next. More than 1,000 people have died. The outbreak was formally declared on May 15, 2026, after Bundibugyo virus infections were confirmed in the Democratic Republic of the Congo and neighboring Uganda. By the 15th of July, the World Health Organization had recorded 2,124 confirmed cases and 828 deaths inside the DRC, representing a crude case fatality ratio of 39%. The numbers continued to climb rapidly after that update. Congolese authorities reported 2,473 confirmed cases and 999 deaths by the 22nd of July, with approximately 50 new cases detected in a single day. The latest reported totals subsequently moved beyond 2,500 infections and 1,000 deaths. Some of the increase reflects expanded surveillance, laboratory testing, and the processing of sample backlogs. That qualification matters, because newly reported infections are not necessarily infections acquired on the day they enter the official count. It does not, however, remove the wider warning. Transmission remains sustained across a large and exceptionally difficult operating environment. Why this Ebola outbreak is spreading so quickly? Ebola does not spread through the air in the same way as measles, influenza, or COVID-19. It is primarily transmitted through direct contact with the blood or other bodily fluids of an infected person, contaminated materials, unsafe clinical care, or the body of someone who has died from the disease. That should theoretically make Ebola easier to contain than a highly contagious airborne respiratory virus. Every infected person must be identified, isolated, and treated, while their recent contacts are traced and monitored before they can unknowingly infect others. That system is failing in parts of eastern Congo. Reports indicate that as many as 80% of new infections have been detected outside known chains of transmission, meaning authorities often discover patients without knowing who infected them or whom they may already have exposed. Only a small fraction of contacts are reportedly being traced successfully, while a majority of deaths are occurring outside recognized treatment facilities. Each missed patient creates another invisible branch of transmission. A person may initially experience symptoms resembling malaria, typhoid fever, or another common regional illness, delaying suspicion of Ebola. Family members may provide close personal care, patients may visit several clinics, and funeral practices may bring mourners into direct contact with an infectious body before the infection is confirmed. A rare virus has removed critical defenses. The outbreak is being caused by Bundibugyo virus, one of the recognized viruses capable of causing Ebola disease in humans. It is rarer than the Ebola virus responsible for the enormous West African outbreak, and has previously caused recorded outbreaks in Uganda in 2007 and the DRC in 2012. There is currently no approved vaccine specifically available for the Bundibugyo virus involved in this emergency, and no approved virus-specific treatment. Medical teams must instead rely heavily on supportive care, including fluids, electrolyte management, oxygen, treatment of secondary infections, and management of organ complications. That is a major difference from outbreaks involving the more familiar Ebola virus species, against which vaccination and specialized antibody treatments have transformed the response. The absence of those established tools makes rapid detection, isolation, safe burials, and contact tracing even more important. The fatality rate has risen as the outbreak has developed. The DRC's officially recorded crude fatality ratio had reached approximately 39% by mid-July, meaning close to 4% of every 10 confirmed patients had died. Previous Bundibugyo outbreaks produced reported fatality rates of approximately 25% and 50%, demonstrating that the virus can be brutally lethal, even though outcomes vary according to access to treatment. Reporting quality and the condition of patients when they arrive. Violence is crippling the response. The outbreak is unfolding across a region already damaged by armed conflict, population displacement, weak infrastructure, and deep mistrust of institutions. Ituri and North Kivu, the two areas reporting the heaviest burden, have endured years of violence involving armed groups and attacks on civilians. Health facilities and response workers have reportedly faced more than a dozen attacks. Treatment centers, burial teams, and medical staff have been targeted by angry crowds, while insecurity has forced some organizations to withdraw workers from dangerous areas. Some health workers have also protested over unpaid salaries. Laboratories have struggled with delays, burial teams have lacked sufficient equipment, and shortages of trained personnel have added pressure to an operation already attempting to cover a large geographical area. Community resistance is especially dangerous during an Ebola outbreak. Safe burial procedures can conflict with traditions in which relatives wash, touch, or remain close to the deceased. Because Ebola remains highly infectious after death, one unsafe funeral can expose numerous relatives and mourners in a matter of hours. The result is a vicious cycle. Fear of treatment centers causes patients to conceal symptoms or remain at home. Unrecorded deaths lead to unsafe burials. Attacks reduce the number of responders. Reduced surveillance creates more unidentified transmission. Rising case numbers then intensify the fear and rumors that produce the resistance in the first place. Could Ebola become a global pandemic? A global pandemic remains possible in the broadest theoretical sense, but it is not currently the most likely outcome. Ebola's method of transmission makes sustained worldwide spread far less efficient than a respiratory virus capable of infecting people through routine airborne exposure. International movement has nevertheless already carried infections beyond the main outbreak area. Uganda recorded imported infections and limited secondary transmission linked to contacts and healthcare settings, although no new Ugandan case had been reported since the 21st of June. Uninfected doctor returning from the DRC was diagnosed in France, while infected humanitarian workers have been medically evacuated to Germany for treatment. Those cases demonstrate that borders cannot completely contain a disease when infected people travel during the incubation period or are evacuated for medical care. They do not, however, prove that uncontrolled transmission is occurring across Europe or other continents. The more plausible international danger is a sequence of imported cases into neighboring African countries, with frequent commercial, humanitarian, and family movement across porous borders. Weak surveillance, delayed diagnosis, or infection inside an unprepared healthcare facility could allow a limited cluster to develop before it was recognized. The risk to the general public in countries such as the United Kingdom or United States remains low because Ebola is not spread through ordinary proximity to an asymptomatic traveler. A patient generally becomes contagious after symptoms begin, creating an opportunity for isolation and intensive contact tracing, where public health systems respond quickly. The danger would rise if the outbreak continued growing, affected major transport centers, produced repeated undetected exportations, or overwhelmed neighboring countries. A worldwide crisis is therefore not inevitable, but neither can international authorities dismiss the possibility of wider regional spread. How lethal is the Bundibugyo virus? The current recorded fatality rate of around 40% makes this outbreak extremely lethal. That figure means the disease has killed approximately 2 people for every 5 confirmed infections reported in the DRC. The true fatality rate cannot be calculated perfectly while the outbreak is accelerating. Some recently diagnosed patients have not yet recovered or died, while other infections and deaths may never enter the official system. If severe cases are more likely to be detected than mild ones, the confirmed fatality rate may overstate the risk faced by every infected person. If large numbers of Ebola deaths are occurring unidentified in communities, the official toll may understate it. Early treatment substantially affects survival. Patients who reach a properly equipped treatment center quickly can receive fluids, symptom control, and support for complications before dehydration and organ failure become overwhelming. Those who arrive late or never reach medical care face much worse odds. Healthcare workers are also at elevated risk because they may encounter undiagnosed patients while providing intimate care. Earlier in the outbreak, more than 100 confirmed infections and at least 25 deaths had been reported among health and care workers in the DRC. Why this outbreak is breaking records. The 2014 to 2016 West African epidemic remains the largest and deadliest Ebola outbreak ever documented overall. It produced more than 28,000 cases and 11,000 deaths across Guinea, Liberia, and Sierra Leone, with additional international cases. The present outbreak has not reached anything close to that total. Its record is speed. The West African emergency took roughly 8 months to exceed 1,000 deaths. The current DRC outbreak reached that threshold in a little over 2 months. That comparison exposes how rapidly containment has deteriorated. The outbreak expanded from 896 confirmed cases and 232 deaths on the 17th of June to 1,460 confirmed cases and 452 deaths by the 1st of July. By the 15th of July, it had reached 2,124 cases and 828 deaths inside the DRC. The expansion partly reflects better detection, but the geographical picture remains alarming. By mid-July, confirmed infections had been reported across 46 health zones in 5 provinces, with 38 zones recording recent activity. The virus was therefore not moving along one narrow chain that responders could surround. It was appearing across multiple, widely separated communities. What happens next? The decisive question is whether authorities can restore visibility over the outbreak. Contact tracing must rise sharply. Test results must arrive faster. Treatment centers must remain accessible. Health workers must be paid and protected. And local communities must trust burial and isolation teams enough to report suspected infections. International financing will be critical. The World Health Organization and Africa Centers for Disease Control and Prevention launched a continental preparedness and response plan seeking approximately $518 million to help countries detect infections, reinforce borders, equip medical facilities, and respond to further spread. Uganda's apparent interruption of local transmission offers evidence that the virus can still be contained when imported patients are detected and their contacts are followed. Its surveillance period will remain important because Ebola outbreaks are not declared over until twice the virus's maximum 21-day incubation period has passed without a new case. The greatest immediate threat is not a sudden wave sweeping across every continent. It is a prolonged and expanding emergency inside the DRC that repeatedly seeds cases across borders, kills thousands more people, and exhausts the health workers trying to stop it. This outbreak has already demonstrated that Ebola can accelerate faster than the response built to contain it. Unless the unknown chains are found, medical access improves and violence against responders is brought under control, the first 1,000 deaths may represent a warning of what is still ahead rather than the peak of the disaster.